Okay, so last time we met, we finished up talking about most of the bones of the skull. And when I say most, we've got one last bone to talk about. It is a big, very complicated bone. As you can see, there's a lot of things listed here that you're going to have to identify. We've got a couple different views here. At the bottom, the first picture. Sorry, that's in black and white. I'll kind of pull up my lecture so you can actually see. It's a real mandible. This has been removed from a skull. You can see the teeth, pretty nasty looking, but they're intact, and we can see some of the structures that are associated with our teeth, like the alveolar process. That was something we drew in when we looked at the maxilla. We would also be able to find the sockets associated with each tooth. The sockets have the special name called alveoli, but since each tooth is actually inserted, so there's no missing teeth, we can't actually see the sockets, but you can see where those would be going in really nice and easily. So I'm gonna jump back here. I'm gonna color in the two pictures at the bottom. I'm gonna just go with yellow because that's a nice color that stands out really well. Okay, we've got our kind of traditional picture that we've seen just about every slide so far. Anterior view here on the left. And then a lateral view on the right. Now, this bone, aside from having our teeth, or lower teeth anyway, or mandibular, or bottom teeth, has the unique ability to move, okay? It's able to go up and down. It's the only movable bone in our skull. And that's what enables us to chew. And these also very important for, like smiling and making all sorts of different facial expressions, and obviously talking as well. Okay. It's got three main parts to each: mandible, the body of the ramus, and the angle. Okay, you can see them labeled here in our cadaver one, the right lateral view as it's labeled. Okay, we can kind of see them labeled kind of periodically down here at the bottom. And the body is the horizontal portion that supports our teeth. So that kind of creates our jawline and then comes to the point and creates our chin. Okay. The ramus is the oblique, which means that it's running at this angle. It's not straight sideways. It's not straight up and down. It's at that kind of in between angle. Okay. It's the oblique posterior portion. And then the angle is just kind of where it does that turn from being more horizontal to more of that random kind of oblique angle. So that's the angle. Okay, you can see them all three labeled over here. I don't know why they don't really label all three of them here. If you want to, you can label those in. Okay, a couple holes are found in this bone, a couple pairs, I should say. The first one I want to talk about is a pair of holes in your chin, each of which is called a mental foramen. Okay, here in our anterior view, you get a good view of both of them, like so. Okay, those allow for passage of nerves and blood vessels of the chin. Mental is a term that always refers to chin, so that's where that term comes from. Like you can see there, mental protuberance. That's basically what your chin is. Not something we have to want you to worry about identifying though. Not to be confused with the mental foramen is another pair of holes, each of which is called a mandibular foramen. Okay, this permits the passage of nerve and blood vessels that supply our lower teeth, and it's on the inside of the jaw. So you'd have to go inside the mouth to find it, unless you have a situation where the mandible's been removed, like you see here in this picture. That's why you won't find it in either of these images. Okay, very important nerve here, supplies our teeth, and that is why a lot of times when a person has dental work on their lower set of teeth, they inject an anesthetic right around this foramen to try to block that nerve. So, when they're drilling or chiseling or whatever they're doing to your teeth, it doesn't hurt. Okay. So there would be another mandibular foramen, it would just be on the other side, but we can't see it. Okay. All right, a couple more structures include what we call condylar processes, which are listed up here as mandibular condyles, and that's actually how I want you to know them. So I will write that out, mandibular condyles. These are the rounded knobs. There are two of them, one on each side. And those rounded knobs fit very nicely in that little notch of our temporal bone. And together, those create what we call the temporomandibular joint. Okay. That notch on the temporal bone was called the mandibular fossa, and that accommodates the nice rounded mandibular condyles that our mandibles have. Okay. And that is what allows for, the act of chewing and, moving your jaw up and down. Not to be confused with the mandibular condyles, which are knobs, are these kind of pointy structures, each of which, and you can see another one right here, is called a coronoid process. Okay. Mandibular condyles are for joint formation, whereas these coronoid processes are sites where a muscle or muscles can attach. Okay. If you guys think back to the other day, we talked about those muscles that connect up here to our temporal lines. They come down from there. They go underneath of this little bridge, our zygomatic process, and they attach right there to those. And that is what enables them to, this muscle here, to adjust, our jaw and make it go up and down. Okay. And that's why when you felt the side of your head and you bit down, you can feel that muscle contracting because it's pulling on that jaw right there. Okay. And as far as other structures go, I already kind of mentioned it, but I'll highlight it again. Alveolar process, that's the bridge or ridge-like arch where the alveoli or the sockets are for our lower teeth, and just like the ones in our maxillae. Don't worry about the mandibular notch or the mental protuberance, like I said earlier. Those aren't things you need to worry about. Questions? Okay, well then we are done coloring for this lecture anyway. Before we move on from the skull, I want to kind of talk about just a few things, and these are all things we covered earlier in the lecture. Most of that was all the other day. But besides forming our large cranial cavity, our skull also forms several smaller cavities. Include your nasal cavity or the inside of your nose, and your orbits or eye sockets, which open to the exterior. And we also talked about the certain skull bones that contain the paranasal sinuses, like in our frontal bone and our sphenoid and so on and so forth. And those open up into the nasal cavity. Okay. Pictured here is a sagittal section of the nasal cavity, giving us a good view of what we call the nasal septum, okay, which I'll refer to again, but let me just read through. The nasal cavity is spaced inside the skull, divided into right and left sides by the vertical partition called the nasal septum. Now, the nasal septum consists both of bone and cartilage. Remember, the two parts that form the bony part are the perpendicular plate of the ethmoid, and then the vomer, which is a facial bone. And remember, when somebody breaks their nose, a lot of times it's septal damage, not actual nasal bone damage. The rest, and it's the anterior part of it, is all cartilage. We call this just septal cartilage, is what you can get pierced. You can feel it's nice and rubbery and flexible. Okay. So those structures collectively help to form that divider between the two halves of our nose. Okay. Over on the right is an illustration showing you our eye socket or orbit, and there are 7 bones that contribute to it. Okay. Another term for your eye socket is orbital cavity, where you find your eyeball and associated structures. There are 3 cranial bones that contribute to it, singular frontal. Okay, then you've got the sphenoid that kind of forms the back part of it. That's there in green. And then in this kind of little orangish brownish color is the ethmoid. And then our 4 facials, your zygomatic, you can see here kind of that peach color, maxilla in yellow, and purple we see the lacrimal. And then if you see very tiny little bit of shade of blue there is a contribution from the palatine bone. Okay. So those help to form the eye socket. Paranasal sinuses are cavities within the certain cranial bones and facial bones near the nasal cavity, lined with mucous membrane, continuous with the lining of our nasal cavity. Their function is to increase the size of the skull without changing mass of bone, increase the surface area of the nasal mucosa, and serve as a resonating chamber for producing sounds. And they're all illustrated here. Talked about the two frontals in our forehead, the sphenoid, which you can kind of really appreciate more here in the lateral view. There are all those little tiny ethmoidal ones, and then two big ones in our kind of cheek area below the eyes are from your maxilla bone, so we call those maxillary sinuses. As far as the images go, you've got enough to worry about with the other pictures. There was just a whole page and a half in your textbook kind of dedicated to these things, so I included it. Not something you really need to worry about for the exam. All right, let's talk about some bones, as the title of this slide is, that are associated with the skull. Not skull bones, but are associated with it. It includes 3 ear bones that we find in each of our ears. So there's 6 of those total, because you have 2 ears. And then a singular, so there's only one of these, hyoid bone. Okay. We call the ear bones auditory ossicles, and they aid in hearing. It includes what we call the malleus or hammer. It's attached to the back of our eardrum. Eardrum is fancily known as the tympanic membrane. Okay. Then attached to it is the incus or anvil, and then attached to it is the stapes or stirrup, and their function is just to transfer sound waves that strike the eardrum, and then those vibrations are carried into what's called a cochlea. Okay. As far as this image goes, just highlight the malleus, the incus, and the stapes. This is an image that we will see again later on the semester. When we talk about hearing, we'll talk about, the structure of the ear, structure of your eyes, and that kind of stuff, all in one lecture. That'll be probably about a month or so. And we do see a couple things that we talked about the other day. Obviously, you can see the temporal bone. The temporal bone had that external auditory meatus that we identified. What you can see labeled here is the canal, and that's the tube within the temporal bone. The opening is the meatus. Okay. Over on the right side, we see the opening known as the internal auditory canal, which was also something associated with the temporal bone that we talked about. And here you can see that nerve that's passing from our inner ear, and this is the nerve that connects directly to our brain. So we'll get into all that stuff later on the semester, but for now, just worry about malleus, incus, and stapes. As far as this image goes, just highlight the hyoid bone. This is a slender U-shaped bone between the chin and the larynx. Your larynx is best known as your voice box. In fact, this is what we commonly call the Adam's apple. The thyroid cartilage is his fancy name. This bone serves as attachment for several muscles that control our mandible, the tongue, and the larynx. It protects our throat as well, but it doesn't articulate with any other bone. It's a unique bone in that it doesn't touch any other bone. It's the only bone in our body that's kind of floating around on an island. Obviously, it's not floating because you can see there's like ligaments, the thyroid membrane there, and there's tendons and whatnot connected to it. It's kind of really small and dainty. You really don't get an appreciation for it here, I would say, in these two pictures. There's a lot going on with something so small and what seems pretty minuscule. It's easily fractured, though. In fact, if you ever watch like any of those crime shows where they're trying to solve murders, one thing they check for when a person's been strangled as a piece of evidence to say that they were strangled to death is this bone is fractured, because when you choke someone, it's gonna put a lot of pressure on it. I don't care about the two bottom images, just the top one though. All right, let's talk about the vertebral column. Also goes by spine, backbone, or spinal column. Makes up about 2/5, so that's about 40% of our total height. Composed of a series of bones called vertebrae, and it functions to protect the spinal cord. Remember, the spinal cord is inside of it. support our head, serve as a point of attachment for our ribs, pelvic girdle, and our various muscles. Okay, looking at the images at the bottom, we've got a lateral view here showing you that it's not just a stack of bones straight up and down. There's a nice curvature of it. Okay, and we can show, unfortunately, on the right side of the page, some examples of abnormal curvatures. We'll get to that here in a little bit. But the function of these various curves in these various different locations is to increase the strength of the column, help maintain balance in the upright position, absorb shock during walking, and help protect the vertebrae from fracture. So think of it, it's going to bend and flex as we move up and down and around in all sorts of different ways. So it's protective in that way. Okay. The total number of vertebrae that we have during early development is 33. But as we grow, several vertebrae in our sacral and coccygeal regions fuse, which leaves us as an adult with a typical number of 26, distributed as following. Okay. In your cervical region, which is just a fancy term for your neck, are the smallest vertebrae, what we call the cervical vertebrae. Okay. There are 7 of them, and they produce a concave curvature, which means that the curvature comes towards the front of the body, the anterior side of our body. Okay. There are then 12 thoracic, okay, which are posterior to the thoracic cavity of the chest. Okay. And they go progressively bigger to here. Notice that they curve to the back. We call this a convex curvature. And then we curve back to the front again, and that's due to the lumbar curvature and the 5 lumbar vertebrae that support our lower back. Okay. Now, going from our first cervical down to the 5th lumbar, we progressively get bigger. So this first one is the smallest, and then this one is the biggest. Now, going back to the other day, we said that there's 206 named bones in the body. Not every single one of these has a real kind of true name. Generally, we just refer to them with an abbreviation, okay? And by that, I mean, we go C1 through C7. That's the names for the cervical. There are special names for the first 2, though. Then T1 through T12, that's their names. And then L1 through L5. So it's hopefully pretty easy to keep those straight, okay? And as you go from C1 all the way down to L5, we just progressively get bigger. And that's because L5 has to be the strongest. The bigger it is, the stronger it is, so it supports the most body weight, okay? Now, the sacrum is bigger than L5, but the sacrum, it's kind of cheating, so we don't classify it the same way. And I say it's cheating because it's actually 5 fused sacral vertebrae. So it originates as 5 separate ones. Generally, it completely fuses around the age of 25, which provides a great strong foundation for our pelvic girdle, okay? Then at the very tip of our spinal column is the coccyx, which we commonly just call our tailbone, and that's made up of 4 fused coccygeal vertebrae, very tiny vertebrae, and they usually fuse completely somewhere around that same age, 20 to 30, so about 25. Okay. As far as this image goes, I do want you to highlight it, know it. Okay. We're going to go through each of the different regions and learn about specifics of them in a little bit, but I do want you to know kind of what the column looks like as a whole. I also want you to know that the 6 images on the right, okay? There's 3 conditions illustrated here. We have actual illustrations and then actual clinical pictures showing you exaggerated conditions where the column has been abnormally curved, okay? Kyphosis, which we commonly call hunchback, is an exaggeration of the thoracic curvature. As you can see here in red, the thoracic curvature gives this rounded shoulder appearance, which is why it gets its name as hunchback. Okay, you can kind of see it here. It's not the best image in my opinion, but it's a common condition that you see a lot in elderly people. Okay, and then if you look here, it looks like a guy with a little bit of hair, not any on top of his head, but it's white, so it's, I guess, depicting an old fella. And this looks like an older lady. Lordosis, or swayback, as it's commonly described, is an exaggeration of the lumbar curvature. So the lumbar curvature comes forward too much. There's a pretty pronounced example of it. Very common. It looks like this lady's got a little bit of a belly, probably is pregnant. Okay, very common in pregnancy When you get that baby in there, especially late term pregnancy, the belly is really far out. It just basically pulls those vertebrae because the center of balance is all out of whack. Now, both kyphosis and lordosis are abnormal curvatures from front to back. So basically, the curvature is too far back or too far forward, whereas scoliosis is a lateral curvature issue. Okay, it's an abnormal lateral curvature from the normal vertical line of the backbone. What we want is a nice straight up and down backbone, but instead it's kind of got an S curvature to it. This lady is demonstrating a really awful example of it. And I say awful, I mean, she's got it bad. Okay. It's a fairly common situation. And, some people live with it, like my wife. She has a little bit of scoliosis, which I gave her a hard time about it, but she survives pretty well without any issue. But I would imagine this lady's got some severe back pain, and it can affect a lot of other things, hips and all the way down the rest of the body as well. So unfortunate for her. I assume that's a lady. I guess it's possible it's not, but any questions on any of those? Okay, what we're going to do now is talk about the different regions of the spinal column, kind of looking at features of them. For the most part, from C1 down to L5, there's a lot of similarities, and that's what I want to kind of first talk about, the similarities that these bones share. Okay, so when we're talking on this slide, we're talking about the vertebrae of the cervical, thoracic, and lumbar regions. Since the sacrum and the coccyx are fused, they're not quite as similar as the rest. Okay, there's no blanks on this page. Okay, so vertebrae in different regions of the spinal column vary in size, shape, and detail. We'll get to that and how they differ more on the next couple slides. Here we're going to talk about how they're similar. Okay, and we've got a couple different images. This is just a look at the top of one, so it's a superior view looking down on it. And then we've got three in a row, and we're looking kind of at a posterior lateral view to show how they connect. Okay, I'll start by talking about the vertebral body, or just the body, which I would highlight here in our superior view and in our figure B. This is the weight-bearing portion of the bone. It is basically just a flat bone, if you kind of separated it out from the rest of it. And by flat, I mean, you can see it's basically flat. It's got a thin layer of compact bone on the outside, and what you'd find on the inside is a lot of spongy bone with a lot of that red bone marrow that we previously talked about in our last lecture. The body of the vertebrae is always what faces the anterior. So this would be pointing towards the front of the body, whereas the spinous process is always on the posterior side. This is a projection that points basically just straight backwards, and you can see it here, and I would highlight there, and as well down here. Important site of muscle attachment. If you run your fingers down your spine, or you palpate, which is a fancier word for it, okay, you'll be able to feel that spinous process. It'll be like little bumps, okay, and I'm sure you all know what I'm talking about, okay. Between the spinous process and the vertebral body is the opening known as the vertebral foramen. This is a hole where you can see that's where the spinal cord will be found. I don't care about you identifying the spinal cord because we're not worried about that at this point, but I do want you to know the vertebral foramen. Okay. Now, going back to this backside of the vertebrae, you will also find two of these, what we call transverse processes, not to be confused with the singular spinous process. But the transverse processes point laterally or to the sides, okay? The spinous process points just straight back. These point out from that, and these transverse processes are also important sites for muscle attachment. Muscles run up and down our spine and connect from spinous process to spinous process. Now, kind of in this same general area, I'm going to mention it, what we call the vertebral arch, which includes the lamina and the pedicle, or pedicel, I don't remember how that's pronounced. It's really kind of hard to tell them what they really are, really in either image. So I'm not going to worry about you highlighting those. So you can kind of jump ahead from there. Okay. So we've highlighted kind of everything I want to highlight here. Let's kind of talk about some things over in this image. Okay. We highlighted the vertebral foramen on this side. It wasn't visible over here, or I guess it is, but we really can't show it so much. Not to be confused with the vertebral foramen is what we call the intervertebral foramen. Okay. Hopefully by now you've gotten used to seeing this prefix inter. That's a prefix. If you don't remember, that means between. Okay. This is a hole or foramen between two vertebrae. Okay. So it's basically just a gap. And this is where our spinal nerves are able to escape the spinal cord. Okay. Spinal nerves connect directly to the spinal cord, and then they run out and connect to the rest of the body. Okay. Well, we don't have one illustrated here, but there would be another spinal nerve coming out right there. Okay, there'd be another one right here if the other vertebrae was included. Okay, that's what the intervertebral foramen is, and I would highlight that. Okay, also we see right below that labeled is what we call an intervertebral disc. Okay, this is a pad of cartilage. I'll talk a little bit more about that here in a second. That protects the two bodies of the vertebrae from just pounding on one another. Think of these like a Dr. Scholl's pad that you can put in your shoe. It's a shock absorbing agent, and you know, very, very great because we don't want the two vertebrae pounding on one another. Okay. Let's see what else. Oh, I got to talk about these two little bumps right here, what we call the inferior and the superior articular processes. Okay. The word articular or articulate, I've mentioned this before, is just a fancy term to describe a joint. Okay. And a joint can be as simple as where two bones actually do touch one another. Okay. Like right here, what this is, you can see it's not labeled here, but it is here, is an inferior articular process. It's a bump coming down from this bone. What this little bump coming up from this vertebrae is a superior articular process. Now in this image where it's labeled, it's saying facet of. The facet of part is showing you like this bluish gray. This is the cartilage, and the pad basically is what the facet of is. I don't really care. The whole structure itself is the superior articular process, and that's what I want you to know. Okay? So every pair of vertebrae, these pair, this pair, they actually do connect. And it's just a little connection between the two of them. And we call those the superior and the inferior articular processes. Okay. So if you have not already highlighted, make sure you have these. I'll just go through it real quick. The vertebral foramen over here on the left. I'm not going to worry about it there. The spinous process, the transverse process, the vertebral body. Down the bottom here, the spinous process. Over on the right, the superior articular process. Intervertebral foramen, intervertebral disc, vertebral body, and inferior articular process. Okay. Now, picture down at the bottom is an example of what we call a herniated disc. Okay. Now, I'll get to that here in a second, but let's just talk about the intervertebral disc again. It's a pad of intergelatinous nucleus pulposus. I don't know where that name comes from, but that's its term. Surrounded by the actual cartilage, it's fibrocartilage, so it's really strong, a lot of collagen in it. We call that the annulus fibrosus. You can see both of those are labeled in this illustration. But what's happened is the annulus fibrosis, and it's probably because of some type of stress where the back was kind of twisted in a way, or it just kind of leads to this over time. It's cracked open, and that kind of jelly-like nucleus pulposus has kind of leaked out. Okay. And that will cause the disc to bulge laterally and can be very painful by putting pressure on the spinal cord or spinal nerve. And you can see that actually taking place right there. Okay. You've probably heard of somebody having a slip disc or a herniated disc. Okay. Very common in the lower back. That's where it probably happens the most, I would say. But it's not the only place. If you've ever heard the term sciatica, that's kind of a general term that people use. It's not the best term because sciatic nerve is one of the nerves, not the only nerve that could be affected. And your sciatic nerve is an important feeder of our legs, which when people have a slip disc, a lot of times it's not just back pain they're experiencing, but also radiating pain down in their legs, and can be very debilitating. As far as the bottom image goes, though, you don't need to worry about it. It's just the top two. All right, now that we've got an idea of how those vertebrae are similar, let's talk about how they're different. All right, we'll start at the top with the cervical region and the cervical vertebrae C1 through C7. Okay. Key features of all our cervical vertebrae, they're very tiny, dainty. Okay. They provide great motion, and that's what allows you to, like roll your neck and shake your head. No, shake your head, yes. Okay. Stuff that we can do a lot more as far as motion goes in the cervical region than compared to like our thoracic and lumbar regions. Okay. Now, I mentioned earlier that, for the most part, vertebrae just have an abbreviation. There are two examples of exceptions to the rule, and that's C1 and C2, which have a special name. You just fill it in, which I do actually want you to know and be able to identify. Start by talking about the first cervical vertebrae, what we call C1. Okay, C1, which goes by the term atlas, is going to be a vertebrae unlike any other because it has no body whatsoever. There is no body weight supporting structure. Okay, instead it's just got a really big vertebral foramen. Okay, and this is called the atlas because I believe it's Greek mythology that is named after the Greek god, the Atlas or Atlas, who holds the world on his shoulders. He doesn't hold the world on his shoulders, but he holds the head on his shoulder. Okay. These little articular facets right here will connect with the bottom of your skull and your occipital condyles and create the connection between your head and your neck. Okay. Now this extra big hole within the atlas accommodates this little structure coming up from the what we call axis. Okay. The axis does have a body, but more importantly, it has this structure called the DENS process that fits right in here, okay? And that enables you to shake your head no, okay? So the axis, which I would highlight here in this picture, both of them, superior and the lateral, that this is the axis, because maybe I'll just put the picture on the exam and say, what vertebrae is this? I would also highlight that it has this structure called the DENS. As far as this image goes, just highlight that this is the atlas. Okay, maybe I'll just put this, say what vertebrae is this. Okay. Here's what C3, C4, C5, etc. look like. The rest of them look like this. Once again, very tiny, very dainty. Okay, have a pretty good size vertebral foramen, but they also, aside from having that big foramen, have two smaller, what we call transverse foramina, if you want to pluralize it. In fact, your atlas and your axis also have those. Okay, each of these is a hole that allows or accommodates what we call the vertebral artery and the vertebral vein to travel up through our neck and are protected thanks to these holes, okay, and these vertebrae. Your vertebral artery is one of the major feeders of our brain. It feeds the back of our brain. The vertebral vein drains blood after it has fed the back of your brain. It comes down through and on its way back to our heart. Okay, so highlight the transverse foramen in this image. Okay. Also, maybe I'll just put this picture and cut everything out of it and say what type of vertebrae is this. You would just have to say cervical vertebrae. Okay. I might ask you to label the vertebral body. I might ask you to label, another feature that they have are kind of forked or bifid. That's kind of a fancy word for forked spinous process. Okay. The last of our cervical vertebrae has a more kind of prominent bump where the spinous process is. We call this the vertebrae prominence. It's not really something I'm going to worry about you knowing. But you can actually feel this. If you feel on the back of your neck, right at the very bottom of it, you'll feel kind of a nice rounded knob. That's what that is. Okay, moving on down to the thoracic region. We have T1 through T12, which are going to progressively get bigger. I don't know specifically which thoracic vertebrae this is. Hey, we've got kind of the same thing, view from above and view from the side. If I were to put one of these pictures on the exam, it would be this one. This is where you can really tell what vertebrae it is. And I've had students tell me it looks like a giraffe. I guess this would be kind of like the snout. Maybe this is like the headish area. I don't know. I don't really see it as well. But yeah, whatever helps you remember. The key feature of your thoracic vertebrae is it's got a spinous process that goes kind of more straight down than straight out. Okay, it points down, and that's why I like this image here from the side. You can't really tell that from above. Okay, notice that there aren't those two extra holes. We don't have those transverse foramina in our thoracic or our lumbar regions. Okay, aside from helping to form the spinal column, your thoracic vertebrae also are important for rib attachment, which we'll get into ribs here in just a little bit. Okay, our biggest, blockiest, our strongest, so far anyway, are the last five. And I say last five, you still have the sacrum and coccyx, but your lumbar vertebrae L1 through L5, big, fat, blocky ones. I've had students say this looks like a moose. Hey, whatever helps you. They're big, bulky, big fat body. They don't provide a lot of motion. Well, they sacrifice that motion for being really strong and protective and supporting body weight. Okay. So large, thick, stout, basically everything. All right, and then that brings us to our sacrum. And we'll go ahead and talk also about our coccyx. Okay. Couple images here is an anterior view and a posterior view. Obviously, the coccyx is not connected, but in a living person that would actually be connected. Okay, because they're not just floating away from the sacrum. Your sacrum is a bony plate that forms the posterior wall of our pelvic cavity. Results from 5 sacral vertebrae being fused together, somewhere 16, 26-ish. Okay, as I've already mentioned. Okay. First thing I want to do is kind of point some things out. If on the exam, whether I do this or not, you probably won't see both of these images, but you'll probably see one of them, I can tell you that. You may or may not have it labeled as anterior and posterior, okay? Now, looking at the image, there's an easy way to tell if you're dealing with anterior versus posterior, okay? If you look just straight down the center of the sacrum, if it's anterior, it's nice and smooth. Whereas if it's posterior, it's got this little ridge, okay? This ridge is called the median sacral crest, which you're going to want to highlight. Okay, that's only going to be on the back side. Okay, and that's formed from the remnant of the spinous processes of your upper sacral vertebrae. So this is those backwards projecting bumps called spinous processes, and when those fuse together, the little ridge is still maintained. Okay, so now this has to be posterior, this has to be anterior. Okay, let's talk now about what's called the sacral ala. This is on the lateral portion of the superior surface. It's a smooth surface formed by the fused transverse processes of the first sacral vertebrae. Okay, and the sacral ala is labeled right here. Okay, you can kind of see it's this flared portion right there. So highlight that. Okay, now not only is it important to know where the median sacral crest is on the back side, but that's also going to help you identify these 8 holes. Okay, if you're looking in the anterior view, you can see one of them. All 8 of them are the same thing. Each is called an anterior sacral foramen, okay, which allow for passage of nerves and arteries to pelvic organs. Okay. The same holes, when viewed from the posterior side, are described as posterior sacral foramen. So it's the same hole. When you look at it on the anterior side, it's anterior. When you look at it on the back side, it's posterior. I don't know. I didn't make these things up. So make sure you can identify anterior sacral foramen, posterior sacral foramen. Okay. All right, let's highlight the sacral canal, something else that's only visible in the posterior view. This is going to run down through the sacrum. So it is a tube, okay? You can't see it. You can see where it starts, but you just have to know there's a tube that runs down through here. It's just like, you know, the hole that's in all the other vertebrae, the vertebral cavity created by the vertebral foramen. This is just a continuation of those, okay? The spinal cord actually doesn't go down through this, but the spinal cord actually ends above the sacrum, and then spinal nerves come down through this sacral canal, and some of them pop out the bottom, what we call the sacral hiatus. And some of those nerves that come down through the sacral canal actually pop out through these foramina, some anteriorly, some posteriorly. Okay. Last structure I want to talk about is labeled right here. It's really kind of hard to show it without looking at the side of the bone, and really don't get a good view of the side, but what we call the auricular surface. Okay, this is where our hip bones connect to our sacrum and form together our pelvis. Okay, the connection between the sacrum and each of our hip bones is going to form what we call the sacroiliac joint. Okay, this is not your true hip joint. The hip joint is between the hip and your femur. Okay, but this is another joint kind of in that general area. Sometimes you hear about ladies having SI joint pain when they're pregnant. I know my wife, she struggled with that a little bit. When you're, going through pregnancy, a lot of changes happen to the skeletal system, which we'll get to a little bit more in the next lecture. As far as the coccyx goes, just identify for the coccyx. I don't care about any processes or numbers or anything like that. So once again, if you did not have these things highlighted, I'll go through them. The sacral ala and the anterior sacral foramen on the left side. I just identify sacrum, sacral hiatus, and coccyx in the middle. On top, the sacral canal, auricular surface, median sacral crest, posterior sacral foramen. Sorry, not median sacral crest, median sacral crest. Not medial sacral crest, median sacral crest. I'm sorry. So as you can see, there's a lot of other stuff that you don't need to worry about. And now finally, we've got one last slide. Kind of wrapping things up. I'm going to talk on this slide about the thoracic cage. All right. Thoracic cage consists of our thoracic vertebrae, which we've already talked about, but also our sternum and ribs, and functions to protect many organs, and as a structure allowing for expansion as we respirate, as we breathe. Okay. Inferior border of the thoracic cage formed by the downward arch of our ribs. We call this the costal margin. Okay. If you think like little boys at the swimming pool when they're kids, like my youngest, I used to be able to do this, but they can like suck their gut in. You can see all the ribs, and you can see that downward arch. Unfortunately, that part of my life is far gone, but that's what we call the costal margin. The word costal, you'll see it several times here on this page. Okay, is a term that just refers to ribs. Okay. Now let's start talking first, before we talk about ribs, about the sternum. A bony plate on the anterior side of our thoracic cage has three distinctive parts. Okay. The first, and I would highlight it, is the manubrium. Then the kind of longest, skinniest part is the body, and then hanging down from that is a structure called the xiphoid process. Okay. Let's talk about three things associated with the manubrium. Okay. The first structure, and I would highlight this, sorry, it's right here, is the suprasternal notch. Okay. It also goes by the term jugular notch, as you can see over here in our cadaver. but that's not the image I'm going to want you to know, and that's not the way I want you to know it. I like suprasternal notch. You can actually feel this. You feel like just at the top of your sternum, you'll feel that little indentation. Okay. There's also two other indentations on both sides of it, each of which is called a clavicular notch. Okay. And this is the notch that accommodates our clavicle. And so this is our collarbone connecting to it, forming what we call the SC joint, sternoclavicular joint, okay, which we'll talk more about in our next lecture. Okay. So those are structures associated with the manubrium. Okay. Also kind of associated with the manubrium is what we call the angle. It's just the kind of line coming across between the manubrium and the body. So highlight that. And then the body really, it's just the longest portion, joins the manubrium at that sternal angle. The xiphoid process provides attachment point for our abdominal muscles. Okay. You look here, you can kind of see it just hangs out there on its own. And if you guys have ever been trained in CPR, which I imagine most of you guys have, since all you guys work in nursing settings, and they teach you when you're learning CPR to find this by finding the bottom of the sternum and then going a couple fingers above that so that you're not pushing on it. Instead, you're pushing on the body. Because when you push down, if you were to push directly on this, that could break free, which could be sharp enough that it could actually puncture a lung. And then not only is the person not breathing, but then their lung has a hole in it. So you really screw them up at that point. Okay. But that's the xiphoid process. Okay, your ribs. One fantastic thing about this, there's 12 pairs of them. That doesn't mean you have 24 different names. Okay, we just have like 3 categories. Okay, what we call the true ribs, which are ribs 1 through 7, and they progressively get bigger. And that's how it goes. 1 and then 7 will be the biggest. And then the 8 through 12 ribs, 8 through 12 pairs of ribs, I should say, are the false ribs. Okay. Now the difference is, and it's really kind of hard to show here, but here's a very nice picture that does show what we see in this kind of brownish orange is what we call costal cartilage. That's the cartilage that connects the rib, which actually ends right here, to the sternum. Okay. If it's a true rib, 1 through 7, it has its own costal cartilage connecting to the body. Okay. Whereas all of the false ribs, 8 through 12, don't have their own connection to the body. Now, 8, 9, and 10 pairs, as you can see very nicely here, have costal cartilage, but they connect to 7. Okay, so that's why they're false. Okay, 11 and 12 are not only false, but they're floating as well. Okay, and that's because they do not actually attach to the sternum. Okay, no attachment to the sternum. So what that means is 11 and 12 are false and floating, but 8, 9, and 10 are only false. Does that make sense? I wish there was 3 different categories, but there's 2 categories and then a subcategory. Okay. So those are the different types of ribs. As far as this image goes, if you haven't already highlighted, make sure you highlight the following: the true ribs, false ribs, and floating ribs labeled there. On the right, suprasternal notch, clavicular notch, the manubrium, the angle, the body, the xiphoid process, costal cartilages, which I do want you to know, and costal margin. Down at the bottom, we've got a couple pictures to show kind of structure of the ribs, and then over here we show how they connect to our vertebrae. Really, ribs are really hard to tell the different parts. I mean, they're very complicated little guys, especially at the back where they connect to our vertebrae. There's kind of distinctive parts like the body that are easy to identify, the angle, which is pretty easy, the head. Then you got these facets, superior, inferior, the neck. There's a little groove. Okay, I'm not going to worry about either of these 2 bottom images or really any of the information in there. Just make sure you know this image. It's really cool to see the real deal over here on the right, but this is the one that's the one I want you to know. And that's because they've got the kind of brackets for the ribs, which this one does not for whatever reason. So Okay, any questions? All right.